because it's a long PowerPoint, long lecture, so I need to start straight away. And it's about descending pathways. First check. Yeah. Okay. Bismillahirrahmanirrahim. Now, the descending pathways is a big term, which means anything coming from above and going down. Anything coming from above going down. Because not as people think they are just the cortical perceval. They are more than that. So they are not, they are anything, any pathways coming from above and going down. So we have then premotor, supplementary motor, and then we have the frontal eye field, and then we have, and then this is the prefrontal cortex, the prefrontal cortex. But we also have these major somatosensory areas, 312, 5, etc. And then we have, of course, you know, the auditory, the visual, and other temporal areas. They all give rise to descending pathway. So from the cerebral cortex and brain stem. Okay? They are concerned with suprasegmental control, mainly of movement. Mainly of movement. I just mentioned they are also involved in modulation of sensing. Now, these the pathways, or the first part of the pathway, descend through the spinal cord to the anterior concept. These are the motor ones, and also to cranial nerve, of course, nuclei, but very important, to other gray matter elements in the brain stem. We call this one the corticospinal. We call this one the corticobulbar. Now, so they go to the spinal cord. This is the major one. This is the corticospinal. Corticospinal tract. Later on, we will discuss them in detail, but they are the lateral and the anterior. And we have some of them end in the brain stem, midbrain, pons, and medulla. Now, so anterior concepts, nuclei, gray matter, and other elements. Now, they have at least 2 neurons. And these 2 neurons are called the upper motor neuron, if you are talking about the motor ones, and the lower motor neurons. In short, U, M, N, and L, M, N. Now, these areas from which we have descending pathways receive afferents. Now, the afferents come to them from different levels in the somatosensory pathway. Now, when we say different levels of somatosensory pathway, we mean the ascending pathways, the thalamus, and so on. The different levels, even the cortical areas, sensory cortical areas, cortical neuron, all of them send fibers to the motor areas. So the motor areas, when the motor area is planning or executing movement, they receive information about the status of the skin, the joints, the muscles, etc. So there is a lot of sensory input to these areas, these cortical areas, from the different levels in the sensory pathway, and these are essential for the motor function. Also, they receive input from the cerebellum and basal nuclei. And the relationship with the cerebellum and basal nuclei is two ways. They receive from them during the programming and preparation for movement, planning and programming, and during execution. Also, the cerebellum and basal nuclei are involved in the process of movement. Now, so from the cerebellum, we receive inputs to cortical areas, and also from the basal nuclei, there are inputs to the cortical areas concerned with a movement. Now, in the cortical origin, the upper motor, we already mentioned them. Just to wrap up, they come from the giant bed cells. We studied them in the histology. You remember the histology of the cortex? Yes. There are two areas in which we have pyramidal cells concerned with movement. And some of these pyramidal cells are very large. You can see them under the microscope, even at lower power. At the lower power of magnification, you can see them. These bed cells represent about 4%. Not all of the descending fibers come from bed cells, but they come from bed cells, 4%, and other pyramidal cells in the two areas, in the two layers of the cortex. And many other pyramidal cells in the primary motor area, mostly layer 5. Because we have them in layer 3 and layer 5, but mostly from layer 5. And these, of course, these represent 1/3 of the descending pathways. 1/3. Because we have another third coming from pyramidal cells of area 6, which is the premotor. Area 6 and supplementary motor areas, both of them represent another third. So, descending pathways have 1/3 from primary motor area, another third from secondary motor areas. They bypass the primary motor area, because they go straight. Because primary motor area makes execution of conscious, skillful movements, while the others deal directly bypassing area 4. 1/3 bypass area 4 and go directly down. So this is another third, and then there is a third which is sensory. So the descending pathways are 2/3 motor and 1/3 sensory. Now today we are going to concentrate on the 2/3, which are the motor descending pathways. Now, these ones, just to finish with them, they influence sensory. This 1/3, they go down and influence and modulate upcoming somatic sensation and other sensations. A reminder again, so it is not only the motor areas, but also the sensory areas. Motor areas, 2/3, sensory areas, 1/3. And a reminder of the cortex, you remember the 6 layers. Now, do you find all 6 layers in all cortical areas? Yani if I take a sample from the primary somatic area, will I find all 6 layers? Huh?
I think you should find the same area.
Yeah. Thank you very much. Will they be similar to the 6 areas in area 4?
Doctor, maybe the concentration of cells will be different.
Yes, the thickness of the layer. So in motor areas, area 3, layer 3 and layer 5 are very thick, and we have very thin layer 2 and 4. Because these contain stellate cells which are sensory in nature. And the other way around. If you take a sample from sensory areas, you will find thick area 2 and 4 and still area 3 and 5. This is in relation to this. So the layers are there, but the thickness and concentration of cells, as your colleague said, are different. And so we have more of these pyramidal cells in layers 3 and 5, and most of the cells, pyramidal cells, giving rise to descending cracks are in layer 5. Now, in area 4, the parts, you know this, the parts of the body are somatotopically represented. Somatotopically representation is fixed. The upper limb is on the medial, the lower limb on the medial side, the trunk is in the border between the medial and lateral, medial and superior, and so on. Superolateral, we have the trunk and part of the head, the face, etc. The homunculus, you remember, similar to the homunculus, the sensory homunculus. So you have the pharynx there, the tongue here, the teeth, the gum. So the homunculus representation in the cortex. Now, the descending tracts. Now we are focusing on the tract, which is the axons, which are the axons of the cells we just described. Now, these tracts are about 1 billion fibers. 94% of them are myelinated fibers, constituting the majority of our motor neurons. Because, as I said earlier, upper motor neurons are found in the cortex, but they are also found in subcortical areas. So the majority of them are myelinated fibers coming from the cortex. Now, some of them end in the brain stem. They come from the cortex now, but they end in the brain stem. What do we call them? The cortical bulb. And then we have others, the majority in fact, go directly to the spinal cord, and these are the cortical spine. Now, some descending pathways start in subcortical regions, mostly in the brain. So we have corticobulbar ending in the brain, but we have some starting in the brain, from brainstem to the spinal cord. What do we call this? Bulbospine. We call them the bulbospine. Now, some of these bulbospinal can be considered as a continuum or a continuation of a pathway. So there are corticobulbar and bulbospinal continuous tracts. For example, if we have we have reticular formation, isn't it? So we have cortico-reticular, and then we have reticulospinal. They can be one pathway, isn't it? One pathway. This is a controversial issue. We will discuss it a little bit more when we come to these bulbospinal tracts. Which ones are connected superiorly to the cortex and which ones are not? They are controversial. Some people say they are, some people say no, they are not. So, but let us have the concept. The concept now, the bulbospinal can be just bulbospinal, but they can be a continuation of a cortical descending pathway. What do they do, these upper motor neurons? The upper motor neurons. Do they all start movement? Or sometimes they inhibit movement? So what are the functions of these upper motor neurons? Both they control movement in different ways. They are bilateral in the pharynx and larynx, and this is a safeguard. These are very important, essential and vital organs. Because if we have a problem in these, people can die. So we, as a precaution, we supply them from both organs. We have a problem on one side, no problem. The other side will take off. So the pharynx and larynx are bilaterally supply. Also, remember, they supply the contralateral half of the tongue, bilateral of the upper face. Remember that we discussed this with the facial nerve, and unilateral on the lower half of the face. And the limbs and other parts are strictly unilateral. Strictly unilateral, which is contralateral. Now, at the beginning I said we have at least 2 neurons. And I said at least because sometimes we have more. We have something between the upper and lower motor neurons. And this is important for modulation purposes, for reflex actions. So we have sometimes some interneurons. Sometimes we have interneurons. Now, interneurons are found, for example, corticonuclear, we didn't specify yet, but the part of the corticobulbar going to the nuclei of the cranial nerves are called the corticonuclear. Now, these, when they supply the nuclei, it is not at upper and the lower motor neuron. There are interneurons in the nuclei of the cranial. And by the way, when you try to remember the connections between nuclei of the cranial nerve, you will find a lot of connections between the nuclei, particularly between the vestibular nuclei and the ocular nuclei, because of the need for conjugate eye movement and binocular vision. So there are connections. There are connections between different ocular nuclei, the trochlear and the oculomotor, because we need to move the lateral rectus and the medial rectus at the same time. So there are there's something called vestibulo-ocular reflex. When you move your head, the eyeballs move in the opposite direction. If you want to maintain looking at a particular, while you move your head, you want to maintain looking at this direction. So this is controlled through a reflex between the vestibular and the ocular nuclei. So there are connections between the ocular nuclei and vestibular nuclei, different nuclei. So these connections are usually through interneurons. So we have interneurons in cranial nerve and in the intermediate zone of the spine. We have there interneurons. As I said, for the purpose of modulation and the purpose of reflexes. And reflexes that contain what do we call them? The reflexes with more than one neuron involved. How do you classify reflexes? Polycydal. Polycydal. Now, I used this prematurely, but no problem. I wanted to write here most of the fibers of the corticospine. Now, most of the fibers of the corticospinal tract, and then they become pyramidal tracts when they cross the pyramid and take to shape in the lower part of the pyramid. They become these tracts, the neurons mostly end in interneurons. So most of the fibers of the pyramidal tracts end in these neurons. They do not end in the cells of the anterior cone cells, motor cells. They end in interneuron, and then from the interneurons to anterior cone cells. So these are the interneurons. Now, some fibers of the upper motor neurons end directly in alpha and gamma motor neurons, but most of them end in interneuron, and of course, like the ones in the anterior cone cells, they end in cranial nerve nuclei, also that. So interneurons are found both in the spinal cord and in the nuclei of the cranial nerve. Most of the fibers end in these interneurons, but some of the fibers end directly in the neurons, in the nuclei and the anterior cone. Now the short, because short in the area, the fibers, these short fibers of the interneurons then synapse with lower motor. These are the interneurons, usually shorter than the other neurons. They are usually found between sensory and motor. And then the descending fibers, instead of coming to the motor, they come to the interneurons. So they are also related to reflexes. related to polysynaptic reflexes. And this is a depiction. This is the corticospinal. This is the pyramidal. Then we have the interneurons, and then we have the connection. This is the sensory interneurons, and then external, similar depiction, but this is a larger view, corticospinal tract, showing you the different relationship through interneurons at different levels. So it's a complicated sort of pattern, but you know, there are interneurons. Now, let us start with the first major descending pathway tract. Now, the by the way, is the corticospinal a tract or a pathway?
Can you repeat the question?
Is the corticospinal a tract or a pathway? Think. Use your new cortical neurons. When do you call a tract, and a pathway a pathway?
Pathway will have three other.
More than one tract, more than one neuron. And if it is one neuron, then it's a tract. Okay. Corticospinal. Huh?
It's a path.
So, how many neurons?
It's one.
One neuron. Cortex, spinal cord.
Yeah.
So one neuron is a tract? Like if it's one neuron, then it's a tract.
Yes. If a series of neurons, then it's a pathway.
Oh.
Now, what if I say the corticospinal pathway? Then we have from the cortex to the spinal cord. Then there are some interneurons. Then we have the anterior horn cells. Now this is a pathway. Because it's a series of neurons. So now I'm going to talk about the tract. The cell body is in the cortex, and the axon ends in the spinal cord. Where in the spinal cord? It could end in an interneuron or an alpha or gamma neurons. This is a tract. The tract ends in two different places. From there, we can start calling it a pathway because it's going to include more neuron in the cell. So the corticospinal tract originate in the cortex because the cell bodies are in the cortex. Now, while they descend, they make what is known as the corona radiata because it is radiating here and there. And now I'm talking corticospinal tract because the corticospinal tract, as I mentioned earlier, does not only contain motor fibers. It contains even sensory fibers from the visual area, from the temporal. So it is coming from all parts of the cortex in a radial fashion. This is why it is called the corona radiata. Corona is crown, radial, corona radial. So it now passes in the corona radial. Then they collect and come down in the internal capsule. But as you know, internal capsule has got projection fibers going in both directions. طيب. The internal has ascending fibers and descending. Most of the ascending fibers come from the thalamus because the thalamus is the secretory cortex, so anybody through the thalamus. So thalamocortical. But we have some striatocortical, some. Go that. All of these are in the what is known as the anterior limb of the internal capsule. Now, from the genome and posterior limb, these are mostly descending corticospinal and cortico, by the way, and cortico, but all of them coming from the cortex, coming down in the internal capsule are found in the genu and the posterior limb of the internal capsule. So it's the internal capsule. And then they all go down through the crus or the crura cerebri of the midbrain. So from the internal capsule, they collect and pass through the midbrain where? In the crus cerebri, in the peduncle. You remember the peduncle? What is it made of? We have tectum and two peduncles. Each peduncle has got tegmentum, substantia, and crus cerebri. I'm going to bring an illustration. And then through the pons, and in a very peculiar way. It's a tract, but when it goes through the pons is mainly made of pontine nuclei and transverse pontine fibers. So when these fibers come down, they will find in their way many elements, gray matter and what. So they have to split. You don't see the corticospinal tract as one bundle. It breaks into many bundles passing between the gray and white matter elements of the pons. So in the pons, it breaks into bundles, and then they collect again in the middle, making in that part of the medulla the pyramids. We see them externally as the pyramids. Now, some of the fibers, while descending, they end in the brainstem, they end in the midbrain, they end in the pons, and then some of them end in the middle. The remaining part make the pyramidal tracts. Now, these pyramidal tracts, they causate in the lower part of the pyramid, and then we will continue the story later. Repeat which part?
The last part. Not the last part, the last part.
Of the last part? The last part of
Yes.
the last part? Actually, coming down, they come coronary diata, then internal capsule, then crus cerebri, then in the pons, they divide into bundles, and they collect again. So far, you are following. Now, when they collect again, they already lost some of the descending fibers because they end in the midbrain, they end in the pons, they end in the middle. The remaining parts are now going to the spinal cord. These are now visible on the surface as the pyramids of the medulla. And there they are called the pyramidal tracts because they were corticospinal and corticobulbar coming together. But once they are done with corticobulbar elements, they are now mainly corticospinal. They make the pyramid, and then they become the pyramidal tracts. Now, the pyramidal tracts, they don't descend straight away, they cross. Mostly they cross, not all of the fibers cross. When they cross, they make the pyramidal decussation, and it is visible on the surface. And then from there, we will deal with them later. But anyhow, we are now following the corticospinal tract through the different parts of the brain. Now, internal capsule, coronal cerebral, midbrain, the pons, and the medulla. They make the pyramids in the medulla. Now, most of the fibers cross in the medulla, and what do they form? When they cross, they form a lateral corticospinal tract. They make the lateral corticospinal tract, most of them. Now, so we have, now let us imagine the right side. On the right side, we have the corticospinal, the pyramid. It crosses to the other side, most of the fibers. But some of them continue downwards on the same side. The ones that cross make the lateral corticospinal tract. And the ones which continue directly, they make the anterior or ventral corticospinal. So we have lateral, large, and anterior, small. Lateral, crossed fibers, anterior, not crossed fibers. Now, this is the right side. Now, some of the descending fibers of the right side also continue with the lateral corticospinal tract. So each corticospinal tract has 3 contributions. Most of the fibers cross to the left side, for example from the right, making the lateral corticospinal. Some of the fibers descend on the same side and make the anterior corticospinal. Some of the fibers continue on the same side but deviate to contribute to the lateral corticospinal tract. Which fibers are coming from the other side? It's clear, huh? Three contributions. Huh? We have the right corticospinal tract. In the pyramid, most of the fibers of the corticospinal tract cross to the other side and descend in the lateral funiculus or the lateral column of the spinal cord as the lateral corticospinal tract. The remaining fibers on the right side divide into two types. Some of them continue descending, but continue descending on the anterior or ventral funiculus of the spinal cord as the anterior corticospinal tract. Some of the fibers continue also on the right side, but they join the lateral corticospinal tract, not the anterior. Where do the fibers of the lateral corticospinal tract on the right side come from? They come from the left side. And they together make the lateral corticospinal tract, which is a small percent. So the remaining continue as the anterior corticospinal tract. A small fraction, 0.3% to 3% of the axons descend as ankylosed fibers within the lateral corticospinal. So this is how it is, and they go through the spinal cord in different areas. This is where they decussate. This is the lateral. So this is the lateral corticospinal. So this is the largest one.
Doctor, I have a question.
Huh?
You mentioned that the corticospinal tract, some of the fibers may end in the pons midbrain and medulla.
Right?
Could you change their name into cortical?
No. I didn't say. I said some of the descending. By the way, if you look at illustrations, they call them corticospinal, and then they speak about some of them and then no. They are descending past motor pathways. Some of them are corticospinal, some of them are corticobulbar. And I have a diagram to illustrate. Now, as I mentioned earlier, mostly in the genu and anterior 2/3 of the posterior limb. Here I am now more specific. I said anterior 2/3 of the posterior limb, because the most posterior part of the posterior limb is occupied by the auditory and visual fibers, ascending fibers. So sensation is mainly in the anterior limb of the internal capsule. Posterior limb mainly motor fibers and descending, some of the descending sensory fibers, but posterior limb, the posterior end of the posterior limb is occupied by ascending auditory and visual. Remember the auditory radiation and the visual radiation or the optic radiation? These are the most posterior part of the posterior. So when I say anterior 2/3 of the posterior limb, because not all of the posterior limb are descending fibers, some of them are ascending fibers. Now, this is the corona radiata. From different parts, let's try this. Yeah, okay. Corona radiata. Of course, you know this one, not related, because I know we didn't have the internal structure of the cerebellum, but we have commissural fibers and we have projection. So these are the projection fibers. This is the internal capsule. Of course, this is the caudate nucleus, and this is the lentiform. Between them, we have the internal capsule. This is a coronal section. In the horizontal section, this is the internal capsule, because it is going down like that, and this is part of the corona radiata. This is the internal capsule. This is the anterior limb, genu posterior. There it's very clear, corona radiata, and then the internal capsule coming down. Now, and this is a beautiful illustration showing you what we have in the anterior limb. We call them the corticofugal fibers and the thalamocortical fibers in the anterior limb. The genu, starting from the genu and posterior limb, you see corticobulbar are there, corticofugal are there, pontine ones, corticospinal are there, corticospinal another group is there. Then we have some thalamocortical here, and then we have the optic radiation from the lateral geniculate. So this is the somatotopy of the topical organization in the internal capsule. Now, in the midbrain, where are they? Now I'm talking about the position. Where are they in the midbrain? They are in the crurocerebri. But where about in the crurocerebri? How are they distributed? First of all, these are the crurocerebri. What nerve is this one?
No.
By the way, in the final exam, we might have some labeling images like this one. So you will have a label there and say, what is this, what is this, what is this, what is this, what are these mammillary bodies, and so on. And the nerves and the pyramids. Now these are the pyramids, and these are the crurocerebri. And this is dissected. We remove the part of the pons to show you the descending corticospinal and corticobulbar inside the pons. And this is the cross section of this is the crurocerebri, and this is of course the substantia nigra, and this is the tegmen. All of this is the peduncle. So we have here, so they are here in this part. And how are they arranged? As you can see, from the frontal, we have frontopontine fibers. And then we have, you see, in the middle, corticonuclear, corticospinal of the pyramidal tract. So these are the middle. Then from the temporal lobe, from the parietal lobe, and from occipital lobe. Now, these are corticopontine. They are corticopontine. Some of them are temporopontine, some of them are parietopontine, some of them are occipitopontine. So they end in pontine nuclei. They end in pontine nuclei. The central part is corticonuclear and some of the corticospinal. And the last piece is completely frontopontine. So frontopontine, temporo, these are pontine. In the middle, corticonuclear and corticospinal. This is so if you find a tumor or anything compressing this part, you expect problems in the corticospinal and corticonuclear pathway, and these for the corticopontine. Now, in the pons, especially in the basilar part of the pons, they are broken into bundles by transverse pontine fibers and the pontine nuclei. So they are not one bundle. Now, when they go to the medulla, we already mentioned that they form the pyramids on the anterior surface, and then the fibers of the lateral corticospinal tract cross to the other side at the spino-medullary junction, and is under the position of the pyramid. Now, here, start again. This is the coronary diata, internal capsule. Then here, this is the crus cerebri. This is the crus cerebri, because this is the substantia nigra. And then in the pons, but because we have them in a section, you don't see them breaking into bundles, but in other sections you can see them. Now this is this outer part of the pons is removed, so this is in the crus cerebri, and there in the pons, you can now see them, different bundles, and then they collect again to form the pyramids, and this is the pyramidal deposition. This is where they cross the fibers that is going to make the lateral corticospinal tract. And this is an illustration of this issue. Remember, most of the fibers decossate. Now, some of them continue directly without decossation to on the same side, and some of them continue directly in the anterior. So this is the lateral, and this is the anterior corticospinal tract. When we go to the spinal cord, where are they? We have lateral and ventral. We have lateral and ventral. They occupy upper medial part of the lateral column. The anterior corticospinal tract do not cross. Strangely enough, they come from the right side. They decossate, for example, to the left side. Some of them dissociate again when they come to supply anterior pons. So they become ipsilateral. They become ipsilateral. Some of them. So they occupy a position in the anteromedial funiculus lateral to the anterior medial side, just lateral to the anterior. Now, somatotically speaking, what do we mean by somatotic organization? If you take the bundle itself, you will find the fibers going to the lower limb are in a particular part of the bundle. Those coming to the trunk, those coming to the upper limb. So it's always somatotic organization of the descending arms themselves. So you can know exactly which part of the descending corticospinal is occupied by which. Starting from the homunculus in the cortex, in the internal capsule, they are already, we saw them, somatotypically arranged. Head in the genu, then the upper limb and trunk, then the lower limb in the posterior. So they are arranged in that manner. The head, followed by the head in the genu, then the upper limb, then the trunk, the lower limb. In the crura cerebri, arrangement similar, upper limb. Why we don't have, in the crura cerebri, we don't have something for the head? Internal capsule, there are some for the head. But when they come to the crura cerebri, upper limb, trunk, then lower limb. These are the corticobulbar. They leave and enter the brain stem. They leave and enter the brain. So,
Because there's a blood in
huh? Going for the cranial nerve, yeah. So, in the crus cerebri, when we go in the crus cerebri down, they were corticospinal and corticobulbar together. But the corticobulbar leaves. The lower part of the crus cerebri only contain corticospinal ones. And in these corticospinal ones, they are arranged upper limb, trunk, then lower. Okay. In the pons also, each bundle, strangely enough, not strangely, subhanAllah, each bundle has got somatotypic organization. Each bundle. So instead of having, for example, if we have upper limb, trunk, and lower limb, and they divide, we expect that when they divide, all the fibers of the upper limb will split, and all those for the trunk will become one. No. Each bundle will contain some fibers from the upper limb, some fibers from the trunk, some fibers from the lower. So the topical organization is maintained even in the bundles in the pons. Of course, in the midallah, the upper limb is most medial and the lower limb is most lateral. Do you remember the ascending pathways? The gracile anteunate, the posterior column ones. The upper limb is on the inside or on the outside? Outside. And here?
Here it's the opposite.
It's the opposite. It's the opposite. Now, in the lateral corticospinal of the spinal cord also, upper is most medial, then trunk and lower limb, similar. And the anterior, upper most anterior. On the anterior, it is not arranged sideways, it's arranged anterior, middle, and posterior. So that we do not confuse things. Very important. Now there are subcortical origins of descending pathways. There are subcortical origins. What are these? Because these are not the same as, they could be part of the same pathway, but they are different tracts. What are they? We have descending tracts from to subcortical structures, not the spinal cord, and these the ones you mentioned, the corticobulbar. So we have corticospinal and we have corticobulbar. But we have descending pathways which are not from the cortex, which are
From the brainstem.
Reticular
Reticular spinal, motor spinal, so what is the relationship between these two? The corticobulbar and the bulbospinal. Some of them are part of the same pathway. So we have, for example, a corticopontocerebellar pathway. So we have a corticopontine and a pontocerebellar, a corticopontocerebellar. The same applies to the reticular formation. We have corticoreticular, and then we have reticulospinal. They are part of the same pathway. But cortico-olivary not confirmed. Some people believe it is there and they actually wrote papers about that. Some people do not believe it. They say that olivospinal is an independent pathway. It doesn't receive connections from the cortex. I mentioned this yesterday, you just remember. Not all of the subcortical tracts have connections with corticobulbar tracts. The proven ones are the reticular formation. What else? The pontine, yes, definitely pontine. And of course, we have the rubral, we have the tectum, tectospinal, corticotectal, question mark, but there is more proof that we have a corticorubral, from the cortex to the retina. But the definite ones are the pontine and the reticular formation. Okay, let us start with the corticobulbar. They, of course, cortico originate in the cortex, and then, by the way, they come with the corticospinal tract to start with, so through the coronary theater, and then in the brain stem, and so on. They occupy these corticobulbar, the genome and adjacent areas of the internal limb. And today, anterior limb of the internal cap, of the adjacent areas of the internal capsule, both sides. Some of these fibers end in the nucleus, and these are called corticonuclear. And they end with others other than the corticonuclear. Others, together with branches of the corticospinal tract, end in the red nucleus, or inferior olivary, reticular formation, or directly or through basal nuclei. They end in them directly, or they go to the basal nuclei, then they connect to these structures. Now, these alert these subcortical areas, the reticular formation, the red nucleus, etc., to act through their own descending pathways, tracts, which we already mentioned, the tectospinal. Okay. One is the corticopontocerebellar, and this is a very important part because it brings information from the cortex to the cerebellum through pontine nuclei. And what are these important for? Why are we connecting between the cortex or the pons to the cerebellum?
For conscious proprioception.
Huh?
For conscious proprioception.
Okay, think about it. They are coming from the cortex. So, conscious proprioception. What do you mean? Conscious proprioception means I am now aware about the situation regarding my muscles and joints and bones. So this is awareness. So it's in the cortex. So how does it relate to the cerebellum?
How I thought of it is that since it's coming from the cortex and since it passes to the cerebellum, then, and the cerebellum's function is for balance and purpose.
Okay.
So it gives information.
Is it information for the cerebellum so that it knows what is happening? Because it already knows through subconscious proprioception.
Yeah, sure. Okay.
It
So
already
maybe
knows.
it gives like a copy of what's happening and to the cerebellum.
Yes, not just a copy, because the cerebellum plays a role in very important motor function.
Yes.
muscle tone, the
Yeah. So
equilibrium.
here's a copy of the.
Not just a copy. While we are trying to do these movements,
Yeah.
the cerebellum plays an important role in coordination, in the balance.
And it's
See?
Is there constant
Yeah.
feedback?
Huh?
Is there constant feedback during the motion?
To allow it to
Super.
act. I mean,
To
here's a-
intervene,
Yeah, to
not just to act.
if there is some. Yeah.
The cerebellum, how does it know that I am trying to move this part or this part?
Through that.
Through this corticopontocerebellar pathway. And then it plays its part in balance and equilibrium and in coordination. The muscle tone is taking place all the time, most of the time, but it needs this corticopontocerebellar pathway originating in the cortex of all lobes, descends the coronary radiate, of course, internal capsule, and then corona cerebratus, synapse, and the pontine nuclei. Then we have the pontocerebellar tract, which crosses to the contralateral side of the new cerebellum. We discussed it yesterday. We said the new cerebellum is the part, the remaining big part of the cerebellar hemispheres. Now you can see them externally on the pons as the transverse pontine striations. And there is the pathway. It's a pathway because it's more than one track, but it's a cortico-pontine pontocerebellar. And yesterday I worked. Now, okay. Now these are those which we didn't discuss last time, which is the bulbospinal, the bulbospinal tract. Mostly, of course, from the brain stem to the spinal, the bulbospinal. The largest one is the reticulospine, and it has got a part that comes from the pons and a part that comes from the medulla. So there is a pontine reticulospinal tract and a medullary bulbospinal or reticulospinal. From the red nucleus, we have the rubrospinal and tectospinal from the superior colliculi. You remember the superior colliculi, part of the tectum, they are concerned mainly with vision. So, and by the way, one of the tests that is illustrates very clearly the role of vision in posture. If somebody has a problem in their proprioceptive pathways, whether it's peripheral neuritis or neuropathy, they cannot feel, subconsciously or subconsciously. So when they are standing, what maintains their posture is not through the property, it's through visual vision.
So if they close their eyes, they will.
They sway and fall. They sway and fall because they are now depending mainly on visual inputs to maintain the posture. So these tectospinal fibers are related to that. Related to that. Now, vestibular nuclei also in the pons and medulla, they send descending pathways, and of course this is also related to what? Vestibular function.
Which is
Equilibrium.
yeah.
Equilibrium. And by the way, what is equilibrium? Yes, what is balance?
Against gravity.
Yes.
So
You position your body or move your body in a steady
yes.
status, straight line without swaying or falling. And when we lose this, whether it is because of the cerebellum, because it's mainly related to that, or the vestibular function, whether it's the ear or the nerves or the spine, the brain stem nuclei, any problem in that, the person cannot maintain equilibrium. And when they walk as if they are drunk. What do we call this condition? Walking. Ataxia. Whether it is cerebellar or vestibular or ear or. And then we have the last one, which is the inferior olivary nucleus. The cerebellum and the inferior olivary nuclei work on something very important for posture and movement, posture and balance, also. and it is called postural adjustment. So when you lean to one side, they adjust. So postural adjustment is the function of this inferior olivary system and through the inferior olivary nuclei. Now, these are the descending pathways. You can see the corticospinal, the lateral one. You have the lumbrospinal next to it. The olivospinal is there. Reticulospinal, the lateral one. Reticulospinal, the medial one. This is the ventral corticospinal, and this is the tectospinal. These are now very quickly. We already mentioned this. The reticulospinal are, of course, two. They're in the reticular formation, but functionally speaking, some of them are excitatory and some of them are inhibiting. This point is very important because I already mentioned there are corticoreticular fibers. There are corticoreticular fibers. So when the corticoreticular stimulate corticospinal tract, it is not always stimulate to stimulate. It can be stimulated to inhibit. And this relates to posture and muscle tone. So, if the corticospinal fibers are damaged, some of the reticulospinal tract will become dormant because they need stimulation from the cortex. Some of them become more active because they are inhibitory. They are inhibiting. So if they are not stimulated, this stimulation is lost, so the inhibition is lost, and so we have features. We will discuss them with the features of upper motor neuron. So very important for posture and so also an important piece of information. The reticulospinal pathways include autonomic hypothalamo-bulbar fibers. What do we mean by that? Why do we need autonomic hypothalamo-bulbar? Some of the fibers come with them. They actually originate in the hypothalamus and they accompany them to autonomic components. What autonomic components do we have? It's a reticulospinal. Because we have hypothalamo-bulbar. Hypothalamo-bulbar means from the hypothalamus to bulbar nuclei. The bulbar nuclei include some autonomic nuclei, some parasympathetic nuclei. مش كده؟ فعندنا hypothalamo-bulbar. لكن عندنا hypothalamo, some of them accompany the reticulospinal to autonomic components in the spinal cord. And you know them. What are the autonomic components of the spinal cord? These are the nerves, yes? These are the nerves.
Yeah.
But in the spinal cord.
We have sympathetic ganglia, but not the one.
Sympathetic ganglia or nuclei, or let us say components, because they are not definite nuclei. It is just the intermediolateral horn of the spinal cord in the thoracic and upper lumbar. So these fibers, they come with the reticulospinal and go to that. And these end in autonomic centers in the medulla and in the some of them in the medulla and some of them. What are the autonomic centers in the medulla? You know them, I know. I know for sure. You just need to think for one second.
The spider.
Huh?
The spider.
Yes. And now let us pause for a while to identify this autonomic function. What is the parasympathetic component? What does it do, generally speaking? What does the sympathetic part, generally speaking, what does it do?
One is fight and flight.
One, the sympathetic is for fight and flight, so respiratory center, motor, and all of these, yes. And
One
then
is rest and digest.
rest and digest. So in these centers, don't only mention the respiratory area, there are gastrointestinal centers there, the satiety centers, the hunger center. There are many centers related to the function of this rest and digest, which is also autonomic, but it is parasympathetic. So anyhow, there are these centers in the amygdala, and they receive fibers through these. And so the reticular in the pons and the reticular, which is a gigantocellular in the amygdala, both of them receive corticoreticular, and from there we have the reticulospinal tracts. One of them is pontine and one is medullary. The tectospinal, we mentioned it already, mainly superior collicular, and we know what it is for. They cross in the tectum and descend through the anterior funiculus, very close to the anterior median fissure, and then the majority of them end in the upper cervical region, because they are mainly related to vision, but movement of the head. Now, they are believed to be concerned with reflex, postural movements of the visual stimuli, postural movement of visual stimuli. The rubrospinal from the red nucleus. What is this red nucleus? You studied the history of the midbrain. That was very large red nucleus because of the copper deposited in it. It is reddish. So what does it do? What are the connections of the red nucleus? Cerebellum.
Yeah.
So mostly related to cerebellum. And receives some connections, query, we mentioned corticorubral query, main input to the red nucleus from the cerebellum. Popular questions in the quizzes and exams. How does the input from the cerebellum reach the red nucleus? Through which superior cerebellar conduct. It also contains fibers going, they bypass the red nucleus. Where do they go? Some of them go to the red nucleus, to the thalamus, then the cortex, or red nucleus, and then rubrospinal. See that? Cerebellum, superior, cerebellar peduncle, red nucleus, some connection to the cortex through the thalamus, and some actions downwards through the rubrospinal. Some of the fibers of the cerebellum do not go through the red nucleus, they go directly to the thalamus and then the cortex. What do these ones do? To the red nucleus now we now know, because they are involved in cerebellar actions. But why is the thalamus and then the cortex? I mentioned this in the same lecture yesterday. Input from the cerebellum to the cortex. What for? Input from the red nuclei, the nuclei to the cortex. What for?
Storage memory.
Huh?
Storage memory.
The memory they keep it in, okay. Some information to be stored. Do we need information from the cerebellum during the planning and programming for movement?
Yes.
Yes. And where does that take place? Planning and programming for movement. Where about it?
The secondary motor
Secondary motor areas. Which are? 6, 8, 9 بروكز اللي هم الأربعينات ده مش كده؟ ما هم أربعة premotor, supplementary motor, frontal eye field and Broca's. So they need information about the status of these muscles and bones and joints so that they plan and program for them. So the rubrospinal originate in the red nucleus, segmentum of the midbrain. They cross and descend through the pons, medulla, and to the lateral funiculus, anterior to the lateral corticospinal. It's an indirect tract through which the cerebral cortex and cerebellum can influence the spinal motor neurons. Although I just mentioned cerebellum direct connection, cortex wave connection. But through these two, the red nucleus influences spinal motor neurons. And what do? They facilitate flexor muscle activity and inhibit extensor muscle activity. Why do we need this for?
It's movement. Any movement needs contraction of one muscle and relaxation of the antagonistic muscle.
Okay, but sometimes we need, to contain the muscle tone. This is done by the cerebellum through this nucleus. But what I was addressing, we sometimes actually said, to be able to move to flex, you need to relax the extensors. But sometimes you need contraction of the agonist at the same time as contraction of the antagonist. Or the prime mover and the antagonist. You need both of them to contract at the same time. For example, if you hold your mobile phone, relax the extensors. The grip will become loose.
Yeah.
We need in addition to flexion, I need also contraction of the extensors. And this function is called coordination. This is coordination of the movement. So coordination of the movement is not only flexor, you facilitate flexion and inhibit extension, for example, but also sometimes you need to go. This is done by the rubrospine. This coordination movement of flexing and extending. These are cerebellum. These are here is vestibular nuclei. There are the red nucleus. So these are the connections with the cerebellum. And now we are talking about this one, which is rubrospinal. But these are all of them. This is the reticulospinal, vestibulospinal, and all of them. But this is the rubrospinal. This is the connection from the. And as you already know, we have connection to the cerebellum cortex through the dentate nucleus to the red nucleus and then down to the spinal cord. Same, it's just a cross section. We have. This is inferior olivary, but this is the rubrospinal. This is the rubrospinal related to postural adjustment also. Now, this is the rubrospinal, we just described. Now, the vestibulospinal, if I ask you to say one word that describes the vestibulospinal. Balance. Balance. And what is balance? I already asked this question. You stand steady and you walk steady. You stand steady and you walk steady without swaying and falling. So vestibulospinal fibers, they originate in the medial lateral vestibular nuclei in the pons and medulla, and they descend uncrossed. They go through the medulla to the anterior funiculus, and this is where we find it as the medial and lateral vestibulospinal tracts. So two tracts in the anterior. Now they terminate in interneurons because we need further modulation at that level. So they terminate on the interneurons in the anterior horn. The medial one bilaterally in the cervical spine because it has got very special functions there. Now, through this, the ear and the cerebellum, listen to this, facilitate extensor muscle activity because you can now memorize. The red facilitate the rubrospinal, and these ones, and inhibit flexor muscle activity in association with the maintenance of balance. So both of them are active. These are facilitating this. So it's a rather integrated function between these tracts. We already saw this. So this is the vestibulospinal tract, but the connections with the different parts of the cerebellum. This is the folliculonodular lobule. You know, it is part of the cerebellum responsible for the folliculonodular lobule. And this is just the different connection. I brought this to remind you of the vestibulo-ocular reflex. You remember this language? Tell me about it. You are all nodding. Just tell us.
The vestibular nuclei, they are connected with the cranial nuclei of the third, fourth, and sixth cranial nuclei.
Yes, okay.
So whenever I move my head, my eyes will move in the same direction.
Do they move in the same direction or they move in the opposite direction?
Opposite direction.
No, towards the sound.
If it's a sound.
The sound is.
But now we are talking about movement.
No, in movement, opposite direction. But in sound, the same direction.
Yeah.
When you move, you are looking this, I am looking this, but then I want to move my head, but I want to maintain the vision. So this movement, the eyeballs move in the opposite direction to maintain visual experience. So this is the reflex. This is there, and you already mentioned these are the nuclei. One question, because it's also popular, the fibers ascending and descending connecting these vestibular and ocular nuclei, they make a fasciculus. The medial longitudinal fasciculus. Thank you very much. Now, last but not least, the olivospinal tract. This is the inferior olivar nucleus. You can see it even when you look at the slide. It's very loud. If you look at the last slide, you can see the inferior olivar nucleus. And this is, from this inferior olivar nucleus, we have the olivospinal tract. Okay? And it is very much connected to the vestibular nerves, containing bumpers. And I mentioned a bumper sticker, a statement describing briefly the function of this inferior olivar nucleus. What is it? Postural adjustment. Postural adjustment. So it relates to cerebellum. This is inferior olivary, cortico. This is, although it's in blue, I already mentioned this. Some people believe that this exists, others do not believe that this connection exists, cortico-olivary. But the connections with the other components are proven. The midbrain, connections with the red nucleus, from the thalamus, from the basal nuclei. There are connections to this inferior olive because it helps in the maintenance of posture. Now, these are the subcortical or tracts with subcortical origin. Briefly speaking, we mentioned at the beginning of the lecture that these cortical pathways have mainly two neurons. One of them is upper motor neuron, one of them is lower motor. The upper ones can be cortical or subcortical. We already discussed that. So we have upper motor. The lower motor neurons are found in two places. Sometimes the connection is direct, sometimes the connection is through interneurons. The motor nuclei, where do we find them? Motor neurons at the end. Cranial nerve nuclei, anterior horn cells of the spinal cord. These are the lower motor neurons. Now listen very carefully. If I have damage of the neurons in the cortex, this is an upper motor neuron lesion. If we have lesion in the tract descending from this cortex, what type of?
No, it's still upper.
Still upper motor. If we have damage to the nuclei of the cranium, then it is. When we have damage of the nerves, the nerve itself, which are the axons of the lower motor neuron, So Nuclear regions and nerve regions are lower motor. Tracts and cortex, upper motor. So we have two types of them. Listen also very good. Damage in the internal capsule. Blood supply to the internal capsule is interrupted. Upper motor or lower motor? Upper motor, it's part of the tract. Corona radiata, internal capsule, corona cerebri, for time problems before they connect with the cranial nerve nuclei. All of these are upper motor neuron lesions. So you can have upper motor neuron lesions due to lesions in the cortex or anywhere in the tract, the upper tract. Now, so the lesions can be due to disease, can be cerebrovascular accidents or vascular accidents, vascular problems, pressure by tumors, pressure by hematomas, and then we can have problems in the CSF, hydrocephalus, raised pressure on the inside, and fractured bones. All these can lead to various symptoms. Now, the symptoms, usually damage is very rarely complete. Damage is usually partial. You usually have some neurons still functioning. So instead of calling it paralysis, it is better to call it paresis. Even if the muscle and limb cannot move at all, it cannot move because it is too weak to move. So it is usually paresis rather than paralysis complete. So we can have paresis, weakness, or paralysis. Usually, most of the time, it is paresis rather than paralysis.
Is this because most of the, for example, the cranial nerves, they receive supply from both sides of like the corticonuclear tract?
This is one cause, this is one reason, and in such a case, it is minor weakness, not major weakness. But even if it is lower motor, facial nerve pulse, it is usually incomplete. There is still some neurons will still remain functioning. Remember when I talked about the penumbra and when we have cerebrovascular accident, the neurons very near to the area of the blockage will die. But when they are a little bit away, they receive some blood supply from neighboring blood vessels, so they survive. So not all of the neurons are dead. Some of them will survive. Now, in addition to paresis or paralysis, we have there is abnormalities of muscle tone, and we call this hypertonia or hypotonia or atonia. No tone, or weak tone, or increased tone. When do we have increased tone? Huh? Yes, but also when, generally speaking. Generally speaking, when you have
that causes
facilitation of the muscle tone. If we have a tract that facilitates muscle tone and that is damaged, then we have hypotonia.
Yeah, if it's hypertonia, then if we have neurons that cause inhibition of muscle tone, it will cause hypertonia.
Yes. If we damage
the inhibitory, it will cause increase in facilitation.
No, you damage the neuron itself?
No, because retrospinal tract, we mentioned that they have facilitatory
yes, and inhibitory. Okay.
If the inhibitory are damaged, it will be hypertonia.
Then there will be hypertonia.
Yeah.
And another way of saying it, if the facilitatory ones, they do not receive facilitation from the cortex, then we remove their facilitation, now they are
so hypertonia.
hypotonia.
Yeah.
But if we have, so we have facilitatory and inhibitory. Alas, when do we have hypertonia? When the inhibitory themselves are damaged. Okay? And then we have inhibition of the facilitatory. Inhibition of the facilitatory.
Yeah.
If we remove this inhibition from the facilitatory, they work more. Then we have hypertonia.
Okay.
You get the
So
idea?
it's due to two causes.
Two causes.
Yeah.
You can have hypertonia because we damaged the inhibitory pathways or tracks to facilitatory. One similar example, not related to this. The thalamus is always active and it leads to the generation of tremors. The thalamus tends to cause tremor if it is not inhibited. If the thalamus is not inhibited, it causes tremor. So if we remove the inhibitory tracks to the thalamus, then tremors occur because we removed the inhibition of the tremorogenic effect of the thalamus. So you need to remember that some facilitatory effects are inhibited. If we remove this inhibition, then this facilitatory effect will prevail, and then we will have a simple result. Now, we already mentioned. Then we have hypotonia or hypertonia. Now, because we have tried to plan a close symposium. So we are selecting the students to present certain aspects. And I need somebody, I'm not going to discuss it a bit, although we already took too much of the time. So I need somebody to work on the difference between spasticity and rigidity. We will define briefly what do we mean, but it's all over the place. I just want somebody to go and listen to the YouTube videos and read and present a very short 5-7 minutes talk about the difference between rigidity and spasticity, physiologically and clinically, or pathophysiologically and clinically. But what do we mean? Whether it is spasticity or rigidity. I will one difference, when I touch the muscle and I feel that it is some sort of spastic. The muscle itself, this is one way of describing spasticity when we touch the muscle. When you try to move the joints passively, then we can have resistance. Depending on the resistance, I'm not going to describe.
Last night.
No, these are the different types. But when do you call it spasticity and when do you call it rigidity? But anyhow, there is resistance to the movement. Whether the resistance when you move, when you flex the joint, it is resistive, the flexion, or when you move the joint to extend it, it is resistive. There is resistance to passive movement. Last. Now, if this resistance is continuous, we call it lead pipe rigidity or plastic pipe rigidity. When there is interruption, then it is cogwheel rigidity. Where do you see this? The cogwheel rigidity. I thought you knew about Parkinson's. Yeah?
No, Parkinson, we didn't take it yet in yeah, we'll take
Okay,
it.
then you will take it. There are tremors in Parkinson's, hill rolling tremors, and then we have rigidity. And this rigidity is lead pipe if there are no tremors, and it is cogwheel when there are tremors. In the same patient. If the patient has tremors, then it's going to be cogwheel rigidity. Anyhow, somebody can tell us about it. Then we have a spasm, and when you have a spasm, the muscle feels this spasm. And then we have tremors. These abnormalities related to. Okay, now the lesions very quickly, mostly due to cerebrovascular accident. I said this was the lecture on the blood supply of the brain. It is a major cause of disease in the nervous system. And we already spoke about the difference between cerebrovascular accident and stroke, hemorrhagic or ischemic, and all of those classifications, thrombotic or embolic, etc. Usually, it can involve what you know as extrapyramidal tracts as well. Now, they are characterized by, because the blood, blood supply is contralateral. The nerve supply. The tracts of the right side supply the left side and so on. So usually contralateral, we call it spastic paralysis. Spastic paralysis or paresis. And so, because it is, why is it spastic? Because there is hypertonia. And why there is hypertonia?
Because there is also involvement of the sublateral tract. So the same concept that we're talking about, the inhibition of the inhibitory and the facilitation of the facilitatory, because there is no inhibition to it.
There is no inhibition of the facilitatory.
Yes. So there is
this is we already explained. Okay. So the subcortical presence of intact subcortical facilitatory, which are increased. Then we have abnormal reflexes because of the hypertonia. Now, if it is hypotonia and you try the reflexes, what do you find?
Pendular.
If there is hypotonia,
the reflex of the remote.
they can be weak or up.
Yeah,
Weak or up.
yes.
If they have hypertonia, then we have brisk or maybe pendular. Brisk, exaggerated. Okay, you already know this. So abnormal reflexes include, what is Babinski sign?
It's a primitive reflex where there is, when you stimulate the
When you stroke,
there
the
will
sole of the foot.
Yeah, usually there will be fanning and dorsal.
This is a Babinski.
Yes.
So when it is there, it is called Babinski sign.
Usually there's plantar flexion and
The normal.
yeah.
And in children, we have Babinski is normal.
Yeah.
Yes.
Okay. So also we have loss of superficial abdominal reflex. It is lost. Loss of cremaster reflex, and then exaggerated tumbling jerks. And you already explained all of that. Now, this is important. There is no muscle wasting. The muscle supplied by this damaged tract, they do not become wasted. Why not?
Because they're hypertonic. The muscle wasting is related to muscle loss because of lack of movement, right?
That's called disuse atrophy, and this takes time.
It's a long process.
That's a doctor. But lower motor neurons secrete chemicals that stimulate the growth of the muscles. And they are not interrupted because this is an upper motor neuron. So the lower motor neurons are still secreting whatever they secrete, and so we do not have this dystrophic damage, loss of mass. So no muscle wasting because the lower motor neuron. As you described, this is Babinski's sign. And this is hyperreflexia. This is even more exaggerated than the previous one. In the lower motor neuron regions, usually involved with corticospinal tracts, upper, still. The upper are usually with the cortical. I already mentioned this. One more slide. Severe paralysis but no atrophy, because I already mentioned that the trophogenic, they call them trophogenic hormones produced by the lower motor neurons are still there. There is rigidity in upper motor neuron lesions, and usually led by, but sometimes cogwheel when there is tremors. And then we have exaggerated deep muscle reflexes, hyperreflexia, and then we could have some involuntary movement. In lower motor neuron lesions, because of the destruction to anterior horn cells or the cranial nerve nuclei or the nerves themselves, peripheral nerve, these are the lower motor neuron. These are characterized by the following. Because of the issue of facilitatory effect and all of that is removed, then we have flaccid paralysis. So upper motor neuron lesion leads to spastic paralysis, while lower motor neuron lesions lead to flaccid paralysis. Atrophy, because loss of the trophogenic factors. And there is something called fasciculation. When you look at the muscles or touch them, you feel flickering of the muscles. This is called fasciculation. And this fasciculation, when the destruction is gradual and slow, they start developing this fasciculation. Then, when the muscles, there is lower motor neuron lesions, the muscles on the side supplied by the neurons are too flaccid. There is over-contraction of the opposing muscles. So we have contraction of antagonistic muscles. So this is why we have postures. People with paralysis will have postures. So these postures are caused by contraction of the opposing muscles. This is the last slide. If we have one limb affected, we call this monoplegia. And we have the half of the body, we call this hemiplegia. And then if we have two upper limbs or two lower limbs, we call this diplegia. And when we have all of them, we call it paraplegia. And then, paraplegia, what does paraplegia? Half of the body.
Yeah.
Upper half of the whole body. And when we have all limbs, then it's quadriplegia. Thank you.